Well, good morning and welcome to another Sunday Coffee with Dr. Childress here. Today I'm going to be discussing the betrayer role in the family courts. And this is a broader role within trauma. There are various roles that sex abuse or child abuse does. And the abusive parent, victimized child, um, protective parent, as well as the bystander. And this pathology we have in the family courts is a sex abuse ripple. It's a rippling of sex abuse across generations. And within sex abuse, there is the bystander role, and the protective parent role is often called the betrayer role. And so I'm going to talk about that within trauma as well as within the broader mental health system that's involved with the family courts. So I'm going to start with a quote from Perlman and Cortese and I want you to notice both the journal article and the journal, the title, Clinical Applications of the Attachment Framework. Excuse me. Relational treatment of complex trauma. So they're talking about the attachment system. They're talking about the using the knowledge, the clinical applications of the attachment system and knowledge about that regarding the relational treatment, the treatment of relationships in complex trauma, and it's in the Journal of Traumatic Stress. And the important thing I want to point out about this is not from family court kind of stuff. This is from real research, real knowledge about complex trauma and attachment and child abuse and things like that. So that's where we need to be grounding our professional judgments regarding the pathology. We need to stop making stuff up and actually ground in the actual real knowledge, especially with this pathology, and I'll explain why. So from Perlman and Cortese, reenactments of the traumatic past are common in the treatment of this population and frequently represent either explicit or coded repetitions of the unprocessed trauma in an attempt at mastery. Reenactments can be expressed psychologically, relationally, and somatically, and may occur with conscious intent or little awareness. So the first issue, primary issue, is that we know trauma reenacts itself. It replicates itself. It does it over and over and over again, trauma reenactment. Sigmund Freud called it the transference, that we are transferring our childhood trauma and patterns to current relationship interpretations. Okay, so it's as old as Freud that we know trauma is being replicated, that is being reenacted for an attempt at mastery of the trauma. And I'll be talking later about play therapy in a different session. And that's the whole idea of play therapy, is the idea of the child is reenacting their trauma in the play, and we help them to gain mastery, and we help them figure it out through their play. And so this is established knowledge that the trauma reenacts itself. In addition, one primary transference countertransference dynamic involves the reenactment of familiar roles of victim, perpetrator, rescuer, and bystander in the therapeutic relationship. That the therapist and the client play out these roles, often in complementary fashion with one another, as they relive various aspects of the client's early attachment relationships. Now, a couple things important about that are the four roles: abusive parent, victimized child, protective parent, and then the bystander. And oftentimes people don't understand the bystander role. There's four roles here. And what the actual trauma, those are actual people. Okay, there's an abusive parent, there's a victimized child, and protective parent role. In the reenactment, in the replication of it, those are false roles. Okay, so it's just parent, child, parent, and it's the unprocessed trauma that's adding the abusive, victimized, protective labels to it. It's just parent, child, parent in the real situation. Now, what Perlman and Cortese are discussing here is how it gets reenacted in the therapy relationship. That's transference of the patient and then the countertransference of the therapist, and they interact to reenact the patient's trauma in various forms as the therapist and the patient relive various aspects of the person's trauma and life experience projected or transferred into the therapeutic relationship. What we have in the family courts is not in the therapeutic relationship, we have it in the marital relationship. So we have the reenactment in the world with the targeted parent. Okay, so it's just where it's located. It's not in the transference isn't in the therapeutic relationship. It's in the actual world is being reenacted. And so that's the only difference between what we know about everything in transference and what's happening in the family courts. Now, I want to point out the important role of the bystander in this situation, because that's the role we're going to be talking about today. The bystander that would be the psychologists, the courts, GAL, parenting coordinators, all the associated people in this trauma reenactment. Now, in clinical practice, the bystander role is also called the betrayer, and that's the role of the one who should protect but doesn't. And oftentimes, this is the mother's role in sex abuse of the child, that she sacrifices a child to the father or stepfather to save her marriage. And so if you're familiar with working in child abuse domain, this is so familiar. It's the betrayer role of the mother. And classically, let me tell you how I encounter it in therapy. You'll get a referral out of the school or something, and the child's acting out. But as you explore why the child's acting out, it doesn't make sense. Things aren't lining up. And there's like little features that are problematic. There's a special relationship between the child and the stepdad that excludes the mother or something. You know, there's just there's things that are worrisome. And then once the pattern begins to emerge, but the child hasn't reported any sex abuse yet. And so what we would do, the therapist does, is intervenes with the mother and talks with the mother about what's happening with the father. And so they have an individual session and begin to activate the mother into her protective role. And what she's basically doing is sacrificing the child to she knows what's going on. And Chloe Madonnas, who works with sex abuse, confronts the mother's role. And Chloe deals a lot with the betrayer role in the family of the mother. She knew what was going on. She just didn't want to know. And as long as the mother doesn't want to know, the child has no one to report to. And so what we do is activate the mother into a protective role. The child then has somebody to report to, and we get the report and protect the child. The other domain is we can activate the child to report to a teacher, let's say. Now, we don't explore the sex abuse or anything, but we open the line of communication between the child and a protective other who could help in that situation. So that's the classic area of the betrayer role in sex abuse trauma. Now, in the family courts, the betrayer, the bystander role, is filled by the forensic psychologists. They are the ones who should protect. They have duty to protect and aren't. Okay, so they should protect but don't. So the forensic psychologists are in the betrayer role, And the reason is that they are being captivated by their own countertransference, their own unresolved attachment trauma, and their ignorance. And they join the false reenactment narrative in the supposed role of the protective other, the ally of the protective parent for the supposedly abused child. So, with this particular pathology, it is really important for you to be competent as a mental health professional, because if you're not, and if you're just coming in with your ignorance, this pathology is going to capture you on your unresolved trauma in your attachment networks that you don't realize you have. It's your countertransference. And you're going to get captivated by that trauma reenactment narrative. You're going to wind up believing the reenactment is true because you want to believe it's true, because you're going to be entering into the protective other role. So we have a protective parent role. Well, you're going to be joining with that in your own need to be the protective other therapist for the supposedly victimized child that's not being victimized. It's a false allegation. And if you, with this pathology, it's a factitious disorder, it's a false disorder. Okay, it's a delusion. It's a persecutory delusion. And it's shared between the parent and the child. It's being induced in the child. So we got a shared persecutory delusion. Now, if you believe the shared delusion as if it's true as a mental health person, then you become part of the shared delusion. You become part of the child abuse. You become part of the spousal abuse of the targeted parent using the child as a weapon, because you have your countertransference need to be a protective parent in this trauma reenactment narrative, and you lack the competence and understanding to realize it's a trauma reenactment narrative and not an actual trauma in the current situation. And the moment you understand what you're looking for, you see the narcissistic or borderline allied parent. You see all the false narratives being constructed. It pops out at you. But if you don't know what you're looking for, a shared delusion, factitious disorder, narcissistic borderline traits and things, symptom features, then you're going to be captivated by it, and you're going to become part of the shared delusion. You will be part of the child abuse. You, as the psychologist, will become part of the child abuse if you believe the shared delusion. So it is so important for all mental health professionals to be competent. And we need to stop applying these made up euphemisms labels, and we need to get back to the DSM, and we need to get back to established knowledge for competence. Attachment, complex trauma, child abuse, family systems, delusional thought disorders, ICD-11 and DSM-5. So, the forensic custody evaluators are collusive participants in the psychological abuse of the child and in the spousal psychological abuse of the targeted parent, using the child as a weapon because of their ignorance, incompetence, and negligent misdiagnosis of the pathology. Okay, so I read their reports. I read what's happening. The mental health people are applying these made-up euphemisms, parental alienation or resist refuse dynamic, and they're not applying the DSM-5. They are getting captivated by their own countertransference, the need to be the protective other of the child. And so they join with the allied parent in supposedly protecting this victimized child that's not being victimized. It's a delusional disorder, and they're part of a shared delusion. But they communicate to the child that, yeah, you're being victimized. That's a true, authentic belief, because I believe it too. Okay, and I'm the therapist. So they are part of the child abuse. They are part of the spousal abuse. A doctor, a psychologist should never be abusing their patient. No, and never. They should, a psychologist should never be part of the child abuse, should never be part of the spousal abuse because of their ignorance. That would simply represent negligent malpractice because they are practicing beyond the boundaries of their competence. Okay. So that is a really bad situation we have in the family courts right now, that the forensic custody evaluators are participating in the child abuse by covering it up, by believing it, by supporting it, by being part of the shared delusion because of their negligently incompetent malpractice. Okay. Now, well, hold on. So, the treatment for the bystander role in sex abuse is to activate the mother, the bystander who should protect, into her protective role, parent role. The treatment for the bystander role in the family courts is to activate the forensic psychologists, the bystanders there who should protect, into their protective role. Okay, so that's where we currently stand right now. That the treatment for the family court pathology is to activate the psychologists into their protective role. The moment we activate the psychologists into their protective role for the child, for the parent, then we get a DSM-5 diagnosis of the pathology as shared delusion, factitious disorder, child psychological abuse, spousal abuse using the child as a weapon. And then we protect the child, we protect the spouse, and we intervene and develop the treatment plan for the factitious disorder and the delusional thought disorder, okay, with the allied parent. And so that's the treatment that we now need to have in the family courts, is elevating the quality of the mental health services in the family courts so they are not participating in child abuse. The psychologists are not participating in child abuse. That just drives me crazy. So here's the two narratives. Okay. In authentic trauma, we have an abusive targeted parent, we have the victimized child, and we have the protective allied parent. Okay, that's your authentic child abuse. In the false reenactment, we have the roles are different. We have the abusive allied parent. They are the ones psychologically abusing the child through the reenactment narrative. We have a victimized child. So we have a child abuse in one way or the other. Okay, it's just which parent is doing it. Do we have the authentic child abuse or do we have the reenactment? Because we have a victimized child. So we should be returning, the psychologist should be returning a diagnosis of child abuse 100% of the time. Okay, let me emphasize that one. When a child is rejecting a parent, a child seeking to flee a parent, the psychologist should be returning a child abuse diagnosis 100% of the time, because that's the only thing that causes a child to want to flee a parent. Okay, the attachment system is goal corrected. It always motivates. It's a motivational system, a direction. It always motivates toward a direction. To get a flip requires child abuse somehow. Either it's going to be child abuse by the targeted parent, authentic child abuse, in which case we need to diagnose it and protect the child, or it's going to be a trauma reenactment narrative. It's going to be child psychological abuse, a shared delusion, factitious disorder by the abusive allied parent. And the protective parent in this is going to be the targeted parent. So when we think again about how to activate in the protective, we want to be activating the protective targeted parent into their protective role. Well, they want to be in that protective role. Okay, the targeted parent is trying to protect their child from the psychological abuse of the other parent, who's destroying the child in these made up false beliefs. Okay, but the psychologists need to accurately diagnose that, and we need to provide the support necessary for that parent. Instead, we wind up undermining that parent, and we put them on supervision, and we don't we misdiagnose a problem, and we think they're causing them when they're not. And so we undermine the ability of the targeted parent to protect the child because of our misdiagnosis. Your misdiagnosis, okay, the psychologist, because you're not competent in the necessary domains and you're lazy. You're not trying to become competent. Okay? You're just making stuff up for things you do not understand. And that's important. If you're making up new pathology, parental alienation, resist refuse dynamic, parent child contact problems, if you're making up new pathology, that indicates you don't comprehend what the symptoms mean. You don't comprehend what that is. It's a trauma reenactment, factitious disorder imposed on another. It's persecutory delusion. But you don't understand any of that. And so you have to make up stuff for things you can't comprehend. No, if you can't comprehend it, you need to be gone, okay, until you do. That's competence. That's standard 2.01 of the APA ethics code. And there's reasons for the APA ethics code. There are reasons that require doctors to be competent. Because if you're not competent in open heart surgery and you're doing open heart surgery, your patient's going to die. If you're not competent in the diagnostic assessment of child abuse and trauma, then you're going to wind up becoming part of the child abuse because of your own unconscious needs and unconscious trauma stuff. Okay, because you're just don't know what you're doing. Basically, foundationally, you don't know what you're doing. So, the treatment in the family courts is to activate and empower the targeted parent into their authentic protective role. So we got empowering the targeted parent, and we got activating the psychologist into their protective role to then empower the parent. A trauma reenactment is a false pathology. It's a factitious set of symptoms. It is a false narrative of child abuse, a factitious attachment pathology being imposed on the child for secondary gain to the pathological and abusive allied parent. Okay, there's the pathology. Okay, it's one or the other. We're talking about the reenactment one. Narcissistic, borderline, dark personality parent collapsing into persecutory delusions, using the child as a weapon of spousal abuse, psychologically abusing the child by creating delusional disorder and this false attachment pathology for their own needs. Okay, so, but if you don't see that, you're going to become part of it. The doctor is, which is bad, and I think they should lose their license. That's how bad it is. The patient, now here, understand this clearly. The patient should never have to educate the doctor about the pathology. The doctor should already know. If the patient needs to educate the doctor about what the pathology is, then that doctor is not competent with that pathology by demonstrated need to be educated about it. Okay, that's just foundational to healthcare. If you're going in for medical concerns, you should not be educating the doctor about what cancer is. Okay, they should already know if that's the concern. You should not be educating the doctor about what diabetes is, or what the flu is, or what metabolic process. The patient should not be educating the doctor about the pathology. However, in the family courts, the parents are educating the forensic psychologist about the pathology. It's a trauma reenactment narrative. It's a, delusional disorder. It's a factitious disorder. And the patients are explaining that to the doctors. Those doctors, by definition, are not competent. By definition, if you're having to explain the pathology to them. Okay, and that's how bad things are. Not only are the patients explaining the pathology to the doctors are child abusers. Unbelievable bad mental health services in the family courts. Unbelievably bad. Now, additional understanding. Dr. Childress should not need to educate the doctor about the pathology. If Dr. Childress is educating the doctor about the pathology, then that doctor is not competent but with the pathology by demonstrated need to be educated. It's not my job to educate them. That was their college degree. That was their training and background. If they are not educated, it is their responsibility to become competent and educated, not mine to teach them. Okay. So this is substantially bad because guess what? We need to educate all these forensic custody evaluators about the pathology, about the DSM-5. Okay, apply the DSM-5. We need to educate them about delusional thought disorders, about collapse of a narcissistic borderline into these, Perlman and Cortese, into the reenactment narratives. We need to educate them about factitious disorders. So holy Toledo. We need to educate them about family systems, cross-generational coalitions, emotional cutoffs. They're just incompetent. And they believe the shared delusion. They become child abusers and spousal abusers, using the child as a weapon. Okay. And they're the doctors, and they are child abusers. They're abusing their client child and abusing the parent. That should never happen. I think they should lose their license. Somebody's going to have to explain to me why a lazy, ignorant, incompetent psychologist, okay, who doesn't know what they're doing, starts working with a trauma pathology they don't understand, becomes part of the child abuse because they get captivated on their own countertransference and become part of creating the child abuse, creating the delusion in the child. Somebody's going to have to explain to me why that doctor shouldn't lose their license for being a child abuser and a spousal abuser because of their negligent, lazy, incompetent, unethical practice. If you're a child abuser as a doctor, I don't think you should have a license. And if you're so lazy, you just ignore the APA ethics code for competence and you just wander in and start treating things that you don't know anything about, I think you should lose their license. So that's my goal, is to get rid of these child abusing psychologists. They should, if you're a child abuser and a psychologist, you shouldn't be a psychologist. You go work somewhere else. Okay. You should not be a psychologist if you're actively abusing your child or abusing a spouse, participating in spousal abuse. So let's do that. We need to get quality mental health professionals, just baseline quality to begin with, but then advanced quality ultimately. But right now, we just need to get competent mental health services into the family courts. So all mental health professionals have duty to protect obligations. From Wikipedia, duty to protect. In medical law and medical ethics, the duty to protect is the responsibility of a mental health professional to protect patients and others from foreseeable harm. Cornell Law School definition of negligence. Negligence is the failure to behave with the level of care that someone of ordinary prudence would have exercised under the same circumstances. I will offer that for a doctor, psychologist, the ordinary prudence would be the application of the DSM-5 to your diagnostic formulations and professional judgments. Okay. So the APA Ethics Code for Standard 2.04 to apply the established knowledge would be ordinary prudence for a doctor, or established knowledge, DSM-5 for diagnoses. So that would be ordinary prudence by a doctor. And I would be representative of that. I'm your basic doctor doing basic doctor stuff in the family courts. So the behavior usually consists of an action, but can also consist of omissions where there is some duty to act. We have a duty to protect. If we fail in our duty to protect, then we are negligent. Okay, so that's your bystander role of the forensic psychologist. That's your betrayer role, the one who should protect and doesn't. That is negligent malpractice. Okay, and violation of 2.04, violation of you know 2.01, violation of 3.04, avoiding harm. Okay, the harm's foreseeable in this situation. So you need to take active steps to avoid harm. What are the active steps? Apply the DSM-5 to your diagnostic formulations. If you're not doing that, you're not taking active steps to avoid harming your patients because you're not identifying at a professional level what the pathology is. And then you're just wandering in doing stuff and messing things up. So, in all cases of severe attachment pathology, all cases of severe attachment pathology, a child rejecting a parent, surrounding court-involved custody conflict, a proper risk assessment for child abuse needs to be conducted to the appropriate differential diagnoses for each parent. All cases routinely. Okay. We know the only cause is child abuse one way or the other. We got the symptom, a child's trying to flee a parent, child rejecting a parent. It's child abuse one way or the other. So let's get it in for a proper risk assessment. Let's take a look at the targeted parent. Let's take a look at the allegations. Let's apply behavioral analysis. Let's take a look at it. Is there child abuse? Rated on the parent-child relationship rating scale. Rated on the parenting practices rating scale. Okay, the 4 different levels. Identify where their parenting is, just to get clarity on where the targeted parent is. Then, if it's not abusive, if there's no abuse causing, then it's not an authentic attachment pathology. We switch over and look: is it a shared delusion? Is it a factitious disorder? And there's ways to diagnose those. Okay, so we need to diagnose it one way or the other. The assessment for a possible delusional thought disorder is a mental status exam of thought and perception. From Martin, of all portions of the mental status exam, the evaluation of a potential thought disorder is one of the most difficult and requires considerable experience. The primary care physician will frequently desire formal psychiatric consultation in patients exhibiting such disorders. So at this point in time, you need to be consulting with delusional thought disorders. All you people and doctors in the family courts, when you get one of these cases, you need to be consulting because you don't know how to conduct a mental status exam. I've worked 12 years at UCLA on a schizophrenia project where I was trained every year by top people in how to conduct a mental status exam to pop out a delusion. You're not. I know you're not trained in that because you're not doing it, for one thing. It's easy. You don't make a diagnosis of a delusion based on history. You pop it out in the session and take a look at it, but you don't know how to do that. So you need to be consulting with somebody who does. Now, typically, those are over in the schizophrenia world. Ultimately, once people want to solve this, then we just get training in for the custody. Psychologists in the family courts, reticent to call them forensic, the court-involved clinical psychologists. Okay, they get training in how to assess for delusional thought disorder. I've already spoken to Joe Ventura, Dr. Ventura at UCLA, and said I might be sending people to training on the brief psychiatric rating scale with you. Okay, so he can come in and train you all on how to do these delusional thought disorders, or I can do it. Okay, if you listen to me. But everybody fights about everything, and nobody's motivated to solve anything yet. Okay, but the AFCC, the licensing boards, I think should be just giving trainings out there to all court-involved psychologists on the assessment of persecutory delusions. Come on, AFCC. But the moment they do that, they admit they haven't been doing it before. They've misdiagnosed the pathology before, and all the top people need to go away because they're malpractice for years and participating in the child abuse for years. All you top AFCC people, psychology people, you need to go away. But now they're going to cover it up and disable the mental health system for their own gains. So we're in that cover-up phase, and a tremendous conflict of interest in the AFCC at this point, because we need to get established practice, but the moment we do, all the top people need to leave the family courts and to go do something else or lose their license, for participating in the child abuse. So that's a very interesting situation. So the appellate system in healthcare for a disputed diagnosis is second opinion. So any diagnosis returned in the court system will be a disputed diagnosis because the legal system is an adversarial system. So therefore, let's get a second opinion on every diagnosis that we have in the family courts. Easy peasy. We have telehealth, look, internet. So the way to get this is what I'm proposed that we just do routinely, is that we have two litigants, each one's making an allegation of child abuse in some way against the other, likely possibly spousal abuse as well, but at least we got a child abuse allegation going each direction. And so we need to get a clinical diagnostic assessment of the child abuse. Which parent is abusing the child? One or the other is. And since it's going to be a disputed diagnosis, allow each party to appoint their own second opinion on the assessment through telehealth. They can be part of the assessment in telehealth, all three doctors consulting. They will return the diagnosis. Then they can then guide the court's decision makings and the treatment plan going forward. So that's the solution. There it is. Boom. Clinical diagnostic assessment. Unfortunately, none of the forensic people currently in the family courts know how to conduct a clinical diagnostic assessment. So they're not competent, and so they need to leave. If I have to explain to them how to conduct a clinical diagnostic assessment for a delusional disorder or a factitious disorder, they are not competent in the diagnostic assessment of the pathology. So they need to go away until they are competent. It's not my job to educate them. It's their job to already know. Now, that's bad, okay? And so I know what needs to happen. There needs to be a major revision within the AFCC. Get rid of some of the top leadership that misled the legal profession, the psychologists who misled the legal profession by making up this new quasi-judicial role for doctors. There's no quasi-judicial role for doctors. They left healthcare. They left the practices of healthcare and experimented on parents and children. The experiment failed, miserably failed. We need to stop the experiment of forensic custody evaluations, return to clinical diagnostic assessments. We got psychologists who are participants in the child abuse. We have patients educating the doctors. It is incredibly bad, the mental health services in the family courts, and needs a major look and major revision. Until we get there, good luck, parents. Okay, this is what we need. And I wouldn't trust your mental health people until they demonstrate that they are competent with the pathology, that they're explaining it to you rather than you explaining it to them. And they don't need to make up new forms of pathology to explain what things are going on. So with that, I am going to wrap up my Sunday coffee talk for this topic area, the betrayer in the family court system, and that is the psychologist. And somebody is going to have to explain to me why they shouldn't lose their license for being participants in child abuse, because from where I sit, that's just lazy, ignorant, unethical, negligent malpractice. They just don't care. So with that, good luck, everybody. Yeah, good luck.